Sir Liam Donaldson used to have a visual that was a jumbo jet crashing every fortnight. So if you looked at the number of avoidable deaths from in healthcare, 230 people dying a fortnight.
We encourage people to own their mistakes. When they make a mistake, instead of trying to hide it, trying to cover it up, we say to them, own it and show it to us, because that's an opportunity for an improvement. That's an opportunity for growth. So you're both very welcome to our podcast today. It's a bit unusual because I have two people in front of me. We have Helen, and we have Helen who is here from the Patient Safety Learning.
Yep.
All right?
Hello.
And we have Dearbhaile, and people listening to this and watching will probably recognise Dearbhaile, maybe not her face, but definitely her name. So Dearbhaile is the marketing manager here for Seating Matters, and she is very instrumental in getting very good guests for the podcast. And she did a bit of research, and Helen, you are the result of that. So Dearbhaile, you're so passionate about this subject that I thought we should have a three-way conversation.
Okay.
So you're both very welcome.
Excellent. Thank you. Lovely to be here.
Good.
Thank you very much.
So we'll start off with you, Helen, and tell us a little bit about the organisation that you are involved with. You're the CEO of it.
I am. Well, the Chief Executive of Patient Safety Learning. We're a charity and an independent voice for patient safety. We're based in a small office space in London, and although we started in 2018 very much UK focused, we do have a global vision around improving patient safety through sharing learning and improving good practice. So some of that through developing our main focus has been the first few years around the Hub. It's a knowledge platform for patient safety. It's now the world's largest repository for patient safety, and it has lots of content about what good practice is for safer care, for awareness raising, reports, peer-reviewed literature, personal testimonies, lots of information, and we're delighted how that's developed.
And that's called the Hub.
Not a very exciting name, is it?
No.
That's the one we thought of at the beginning, and then we've still got it. So yes, Patient Safety Learning's the Hub. And we've grown from that knowledge base, which is the website, to a whole series of networks of collaborations and communities of interest. To inspire, inform, champion safety improvement, but also to, hold health systems to account for needing to do more, because patient safety and avoidable harm is such a big problem and hasn't been improving at the pace that many of us working in the field that's neaded.
Well, I think that's where we have a meeting of minds. And Dearbhaile, when did you meet Helen, and why did you think Helen was going to be a good guest on our podcast?
So initially it came through one of our contacts in London, I think, reached out, saw what you were doing on LinkedIn, reached out and got in touch on LinkedIn, and then she passed your details over to me. And then Martina and I had a look at it. We went on to the Hub, we created a profile, and when we saw the types of material that was on there, we were just so impressed with what you were trying to do.
Thank you.
It blends in a lot with our philosophy of sharing knowledge and sharing best practice among people, especially among clinicians and healthcare professionals, to let them just share the best way of avoiding patient harm. It's something that we at Seating Matters, Posicare and the Tierco Healthcare group of companies, we feel so passionate about. So the fact that there was already this hub of information there, I thought it was excellent. But one thing that we sort of noticed was there wasn't really much on there about the importance of sitting or posture even, and how that can input into the prevention of pressure injuries and the management of pressure injuries. So it sent Martina and I off on a bit of a down a rabbit hole, and here we are.
And if I can follow up that, so when you first got in touch, and exactly as you've outlined, your organisation's values and our values and what we want to achieve just seemed so well aligned, and so the opportunity to come and learn from what you do here is amazing. But to contribute on the podcast was just like a no-brainer, really, and I'm sure we'll get into it as the interview progresses. But being able to understand how you've developed your not just product for the benefit of patients and carers, but how that philosophy is embedded throughout your organisation, and the patient and the carer at the heart of what you do. I mean, that's something that is so important to us when you think of safety system thinking. Everyone is contributing to delivering safer care, whether you're a clinician, an academic, an educator, someone from industry, patient safety manager, everyone working with safety as a core purpose. And so being able to contribute to you through the podcast, but also to be able to share some of your insights. I think that's something we'll continue the collaboration. We'll be able to put more information on the hub for others to benefit from.
So why it resonated with me as well when Dearbhaile brought it up was that, when I do my presentations or training, one of the things we talk about is transforming specialised seating across the world. And in order to transform that seating, we have to talk to everybody. We have to talk to, you asked me earlier, do we actually get to talk to health ministers, people, talk to procurement, talk to nurses. We need to, because it's not just one person or one discipline, that this has to be across. And that's the same with patient safety.
Yeah.
So that we're aligned like that. So how are you managing to reach out to all those people?
Well, it's not easy.
No.
And I suppose part of the reason why we set up patient safety learning is we felt that there was a missing piece that we could maybe contribute to help promote that sort of system-wide thinking and sharing the knowledge in a collaborative way. Healthcare is very complicated and complex, and not just in the UK but internationally. Someone described healthcare as full of tribes, full of silos. So trying to get that collaborative, cross-organisational, cross-system learning isn't easy. And we felt that with our hub we could help with that. But I think it's the networks and the partnerships that we've developed, finding like-minded people who all want to make that transformative change. And your colleagues were at a wound care conference that I contributed with a colleague last week with our partners, patient public projects, talking about value-based procurement. And that sounds quite sort of stuffy and technical, but it's really about making sure that the best interest of patients and their carers are designed into how you provide services and support, including products. And I know that's something that you're passionate about, that the longevity of the product and the impact on patient care and their therapeutic journey is really important. But that's not necessarily a quick win.
Because it's not a priority for everyone, this value-based procurement.
It means working, as you say, with different partners in that healthcare system, but where budgets are annualised, or savings that could be made by improving care that might reduce length of stay in a hospital, may reduce the risk and the severity of pressure injuries. But the cost of providing better quality mattresses on beds or seating comes out of a different budget. So the savings are not attributable to the people that are incurring the cost. So you've got some real kind of organisational, structural and systemic barriers, and we need to break those down in the way you talked about, bringing a whole range of people together to put safety at the core.
So the OT show's coming up, and Dearbhaile has very nicely asked me to speak again. So, and one of the things that we're talking about, which is what you're doing at the minute, is Yoko 10. But maybe Dearbhaile, you would be good at explaining what Yoko 10 is, because you're doing it. You mightn't call it Yoko 10.
Well, I didn't know the term until yesterday, and I'm like, that's what we do. So
that's exactly what you do.
Yeah.
So Yoko 10 is it's a Japanese phrase, and it translates as sharing information laterally across an organisation. So it's about giving a platform or creating a space where people can share information among each other. And that's exactly what we talked about earlier, sharing best practice among clinicians. And so we do it here every day. Anybody who's been to our factory or been for a visit here, you'll know that we have this culture where we're always trying to improve, and Yoko 10 is one of the ways that we do that. We share our experiences from different department to department. So, for example, the welders could make a change in their area, and that might inspire us in marketing team or in the sales team to make a similar equivalent change in our part of the business. So it's only by having the platform or the location where we can share ideas laterally across the organisation that it can inspire other people to think a bit differently about how they're doing things. So I think that's exactly what you're trying to do.
And I think it's the reflection that we all need to be learning organisations, but it's learning and applying that learning. So one of the key themes that we've been talking about, particularly in light of NHS England have produced 10-year plan, the government's kind of vision for how it wants to transform healthcare with a number of key priorities. One of the key themes for us is that if you do know what good practice looks like, either because you've kind of evaluated it, or you've made changes to respond to avoidable harm, so you've understood the contributory factors and you've addressed those, learning about what good looks like is of comparatively little value if it's stuck in one organisation or one directorate or one ward. It's how do we share that knowledge more broadly? And so absolutely, it's what you're talking about. It's kind of learning for impact so that you're actually making those changes. And going on your tour earlier, fascinating, was the authority and the autonomy that people have to make changes in their own areas. And often in healthcare, you feel that people are almost slightly disenfranchised from being able to do that. And some of the successful organisations in the NHS have embraced that thinking and have given authority to people to make those changes. But I think there is much more that needs to be done to share that practice. And ultimately, a lot of that comes down to leadership commitment for that and the culture of the organisation. And I'm sure talk a bit more about your journey on that.
Culture,
Well, can I just ask, just before we go any further, you've mentioned avoidable harm a few times. Could you maybe give a few examples as what avoidable harm looks like in healthcare?
Well, I suppose you could. It sounds trite, trivialise it a bit, but if anything could go wrong, healthcare is very complicated, very complex. Anything that involves lots of people in terms of engaging with patients, families, carers, loads of clinicians, things will go wrong, processes will go wrong. So if you look at some of the statistics, 1 in 10 hospital admissions in healthcare, something goes wrong, and 50% of that is preventable. In the UK, well, in England, it was considered back in 2000 when the big report came out, Organisation with a Memory, you've got 11,000 avoidable deaths a year, and I would say probably that's increased to close to 20,000 now with the pressure on emergency services in a post-COVID environment. So examples could be medication errors. So I'm going to ask you a question. I guess how many medication errors there are in England in any one year? Pure. Everyone gets it wrong, so don't worry about getting it wrong. But I mean, just the scale.
100,000.
237 million.
What?
And that's a figure from NHS England. Now, not all of those lead to harm, but many of them do. And the harm might be quite minor. But when you think, you've got the wrong, you're being prescribed something that's not in your best interest. You've got contraindications. You don't take it properly, and then you get surgical safety issues, which is why World Health Organization produced its safe surgery checklist, so that you've got kind of different ways of making sure that you've got good practice designed in. So you've got the kind of pre-incision checklist, so that you've got everything in the right place, everyone knows their roles and responsibilities, that you've got all the equipment you need in case something goes wrong.
So are there standards across an operating?
I was about to make the joke, a standard operating procedure is SOP as well.
SOP.
So it's literal in its surgical environment.
Yeah, there are. It is. There are I think when World Health Organization, and I was working for them at the time, looked at safe surgery, it's how do you find ways of making it easier for people to do the right thing, so that they've got the right training, they've got the right resources, they've got the right processes, they've got the right organizational culture. And one of the mechanisms that they used was to create a checklist of having everything at the same time. Now they called it a checklist, and there's lots of I'm learning from other industries like aviation about checklists, but going around your factory, you've got lots of SOPs, but they are visual. They're not kind of stuffy documents that are sitting on a shelf in an office somewhere. You've got a visual right where you need it. If you're not sure, you can flick through all the visuals. So it's lots of ways of helping design systems for safety and providing staff with the information, the resources that they need to do the right thing.
Do you see that visual, like that Gemba visual thing, as something that would be useful in a healthcare setting? That visual, like...
I can't pretend to be an expert in designing these SOPs, but one of the initiatives that's been happening in England, which is a very positive one, is a new initiative called PSIRF, Patient Safety Incident Response Framework, which is trying to get a better understanding when things do go wrong, and there are incidents of predominantly of unsafe care, better understanding what the contributory factors to those are. So rather than blaming an individual and saying, well, nurse X, you need to go on a training course and make sure you don't make a mistake again. It's trying to look at, well, why did that nurse make the decision at the time that he or she did, and what were they intending to do, and if they didn't follow a procedure, well, why was that? And trying to look at organisational factors, task factors, process factors, cultural factors, as well as factors around the staff and indeed patients, families and carers, and trying to understand all that. And there's a very good example that a colleague of mine, Claire Cox, she was looking at how people with mental health needs were being responded to in an emergency department, and clearly there were challenges in providing the support that they needed, but getting people in that ED to better realise how people with mental health service users could be best treated. And so she brought as part of that response framework, she brought a whole team together, and she wanted to look at what the SOPs were. What are the guidelines in place? And
so just for anybody listening that's not sure, SOP is a standard operating procedure.
And so she brought them all into a room, and she discovered that there were over 60 standard operating procedures and guidelines, which she put up all on the wall. And most of the people that were in the room didn't know that they existed, and that they had been written they'd been written over time from the perspective of the person that wrote it, rather than looking at the work as done. So there was in safety, there's often the reflections on work as imagined, work as prescribed, and work as done. And work as imagined is often what very senior people will consider the reality is. So, for instance, in that case, you've got 60 standard operating procedures. The senior people may not know there are 60, but they may be familiar with many of them, and that they would expect that if there was an error of some sort, or there was avoidable harm, that one of the responses might be, well, you should have followed the procedures. But actually, unless you know whether the staff know the procedures, whether they're workable, prescribing, telling people how to implement them, if you don't understand the operational reality, the intensity of the work patterns, fatigue, that you've got these contradictory guidelines, putting yourself in the position of the nurse that's making decisions, you need to understand that to be able to go, well, what is it that we need to fix? Because if you're just telling people what needs to be done and not helping them with the right tools to make it happen, you're not going to make the improvement. And it's going to be very frustrating for staff going, oh, here's another SOP that doesn't really understand.
What do we say in Seating Matters?
About what?
About if there's a mistake,
Oh, yeah.
about the person. You know,
Attack the process and not the person. So yeah,
Absolutely.
that mindset of, and if there's been a mistake, if there's been a defect, it's not that the person has done wrong. It's that the process was set up incorrectly to allow them to make that mistake.
Yeah.
So
Yeah.
therefore we go back, we revisit the process, make sure everyone's trained in the process, and then the defect doesn't reoccur.
Yeah, absolutely. And the kind of the SEEPS framework, one of the tools in PISA is SEEPS, system engineering for patient safety, and it invites, and there are a number of other methods that people will use, but this one I think is a pretty compelling one. And I can share with you, because it's all on our hub, some guides and how people might look at that, because you're looking at task, you're looking at process, you're looking at people, you're looking at organisational factors as well. So you want to take all of those into account, and some of what you're doing here meets that very well, but you don't describe it in quite that way.
Yeah.
But
Yeah.
it's all for the purpose of actually making sure it's as easy as possible to do the right thing.
And I think that feels like that's part of what the hub is trying to do. Like here, we follow this lean culture and lean mindset and lean training. And we have a business that does tours called Lean Made Simple.
Yeah.
We try to make it accessible, and that feels a lot like what your patient safety learning hub is there to do, is to make patient safety accessible to as many, because it's not just for clinicians, sure it's
No,
not.
it's for everyone. So it's a free resource for anyone to use.
Including patients and their caregivers, families.
Absolutely. So that, it's people can just use it as they wish. But we do invite people to register and to tell us who they are, and then we'll send them a monthly newsletter. But we from that we can kind of see which part of the world they're from. 40% of the people that are using the hub now are outside the UK, so it's becoming more of a global resource, which is fantastic. So we know that it's clinicians, so it's frontline clinicians. It could be clinical managers and sort of directors, chief nursing officers, chief medical officers. It could be patients, families, carers. It could be campaigning and advocacy groups. We work quite closely with some of those because we can give them a voice. We're effectively a publishing house now, the hub. So if they've got a campaign, we can share that, demonstrate that. We do quite a lot with awareness. A lot of charities do. It was Mental Health Awareness Week, and I know you were doing some work on that, so we can promote some of that. We work with a number of the charities, like Parkinson's. We know for Parkinson's patients coming to hospital, their medication, it's very critical, time management, and if you miss the dose, that actually compromises you not just on the day, but can have a long-term impact.
Yeah.
And a very high proportion of Parkinson patients that go into hospital for something that's unconnected with Parkinson, just don't get access to that, and staff haven't particularly been trained or made aware of it. So we work with those groups, and then we work with a lot of our networks are people that work in patient safety, so patient safety managers, patient safety specialists who may have a specific role on improvement and quality improvement, but will be the investigators in understanding what's gone wrong if there's a patient safety incident. So anyone at media, journalists, politicians.
But you also encourage people to put stuff on there. I know you edit it and you look at it, make sure it's correct, and that sort of thing.
Yes, it's a moderated site, so we do, for quality control. We've hardly had to intervene on anything over the years. So if people want to share their experience, their personal experience, or they want to share some good work they're doing, or they want to share their frustrations, they can to awareness raise about what more is needed. We would welcome that. So rather than it being just here's some good stuff, have a read, actively contribute. And more in the last few years, people are sharing those perspectives, whether they're individuals, whether they're NHS organisations, whether the independent sector, whether they are commercial companies. We don't promote products, but we celebrate and share where goods and services have made a difference and have improved safety. So anyone and everyone can add to it. So, you can get a lot of information, just putting stuff into Google. of course, but you might not know what you're looking for, whereas we've got a taxonomy, a structured framework that hopefully helps people navigate their way around.
For me, it's reassuring that it is moderated content, that it's, it's not just a free-for-all, that anybody can upload anything. It is, that there is quality control.
That was very important for us at the very beginning, because we weren't sure quite how it would be used. And, you've seen how some social media sites can be very hostile, and it's all about collaboration, partnership working, a culture, a just and restorative culture. So we didn't want it to be used as a vehicle for someone having a go at a clinician, and we were concerned about that, and so we put in thoughtful principles and moderation to prevent that from happening. In the end, we haven't had to take action, so it's been fine. But, it's important.
Just going back to something again that it reminds me of what we do here, of our culture and of what you're trying to do. And it's we celebrate, or we don't maybe, and we encourage people to own their mistakes. When they make a mistake, instead of trying to hide it, trying to cover it up, we say to them, own it and show it to us, because that's an opportunity for an improvement. That's an opportunity for growth. So the same with your patient safety. People are probably are worried about, emphasising a failure, like a whistleblower, because
they are. And the whole point about safety culture, and particularly if you look at other industries that have done more in this area, some cultures, they actually, if you put in a requires improvement, I made a mistake, whatever, into a box at the end of each month, there's a raffle, and one of them is picked at random. Someone is awarded a laptop or something. It's to encourage that. And again, the NHS in England, and I'm sure this is Wales and Scotland, but I'm less familiar about them. But they do annual staff surveys to find out, and they're starting the last few years have been asking questions around patient safety, and the results are not great. They around 40% or so of staff say they don't feel confident about raising concerns. They're not sure that they would be treated fairly. They're not sure whether that would be acted upon if they raise those concerns. So, that's a really big indication of whether you've got that learning culture right or not. Because if you're not doing what you do and listening to the front line and encouraging them to identify improvements, either because they've done something that isn't according to the SOPs, or it might be that they can see that there's a way of improving that. That's gold dust. I mean, if you look at management consultancies, that's how they make their money. I mean, they do more than this, but a lot of management consultancies will come in to address a particular problem, and then they'll go and speak to frontline staff and find out what's really going on. Well, management can do that. If you've got those commitments and those flattened hierarchies and you're listening.
Do you see, when we hear it on news, we hear, where there's been a really big incident in a healthcare, and it's investigated and they come up with all these recommendations. In your experience, are these recommendations always carried out, or is it just a paperwork exercise?
Have you read? We did a report on this a couple of years ago called "Mind the Implementation Gap," and that was specifically about this very issue. That if you look at the big inquiries, if you look at current reports from coroner's inquests, if you look from local investigations, all these opportunities to better understand what has gone wrong, what should have happened, what needs to happen to prevent future harm. Those aren't implemented, or they're not implemented consistently, or the evaluation frameworks aren't sufficiently rigorous to evidence the improvements that have been made. So it's very patchy. And the Health and Social Care Select Committee in Parliament picked this up as an issue a few years ago, and they did kindly cross-reference our report in it, and it's a really big an important issue that we emphasise the whole time. It's just not sufficient to have the recommendations. You've got to be able to apply them. And so the healthcare system needs to have better ways of knowing whether that's happened or not.
Yeah, because there's, apart from anything, they're spending millions of pounds doing the investigation.
Well, yes, and the OECD, they're great, and they've taken patient safety to their heart, and they've got a number of very, very thorough reports. You'll be able to find them on the hub, obviously. But and they did one on medication safety, actually, linked to a global challenge that the World Health Organization put out a couple of years back. But their substantial piece of work was looking at, well, what are the economic impacts of patient safety? We know the harm it causes to patients and families. We know the distress it causes to caregivers and staff. But what's the wider socioeconomic impact? And they found in the developed world, between 13 and 15% of all healthcare spend is attributable to avoidable harm. So the cost of not doing it right is huge. So looking in England, just based on the figures, if you could reduce that and take that down by a half, you'd be releasing £8 to £10 billion a year. So kind of morally, patient safety has to be a core purpose and a driver for change. But economically, we're wasting money not doing the right thing. And then there's a wider socioeconomic benefit or disbenefit to families, because if you've got someone that's very unwell or disabled or has died and is not able to be economically active, that's making a big difference to that family or to the wider society. So it is one of the top 10 leading causes of death and disability in the world. So it's a significant issue. I mean, more people in the US die of avoidable harm in healthcare than road traffic accidents. So the scale and impact of it is not widely known, I don't think, and it's not driving the ambition for change that it needs to have.
How close do you get to the policy makers of the policy, the ones that make the decision? Or, is that a big focus for you to get as close to?
Well, the decision makers are all over the place, aren't they? So you've got local decision makers, budget holders within an organisation. You've got chief nurses. You've got chief execs, boards, policy makers, as in government or NHS England. And we think, in terms of safety system thinking, all parts of that system need to coordinate and align to put safety as a core purpose, as a priority. So some of our reports are very focused on influencing decision makers at a policy level. Some are much more, obviously with the hub, there's a lot of practical content. I was at the awards, I don't know if you know about the Picker Institute.
No.
Fantastic. And they are a charity in the UK. They're quite well established over a number of years, but they run picker engagement networks, and they do an annual awards ceremony, which demonstrates good practice in patient safety. So fantastic. I went to their award ceremony last couple of weeks ago, because we think next year we might do one specifically on patient safety or patient advocacy and patient safety. So that's still working practice. But it can be very clinical practice. There was one lady there that was talking about her project that she got shortlisted. She didn't win, but it sounded fantastic, which is called Go Decaf. So she was looking at patient falls, particularly in care homes, and some of that was contributed by urinary incontinence and people needing to go to the loo, and some of that was because the drinks that they were being offered were caffeinated. So by reducing caffeinated drinks, so either going decaffeinated or providing other drinks, they'd reduced falls by 40% in all the care homes. I mean, those really very practical initiatives are fantastic. But I think it's using the evidence base from where it works and trying to get those policy makers, getting the chief execs, getting the chief nurses, chief medical officers and politicians to understand why this needs to be such a priority. One of the things that we've been doing with one of our networks, which I think is fabulous, is Patient Safety Paediatric Leaders Network, because we work very closely with Great Ormond Street Hospital. The idea of having a network of all the tertiary paediatric hospitals. So there's a network that meets monthly of chief nurses or deputy chief medical officers. It's a community of interest sharing their ideas, but it's generated some development work around solutions around total parental nutrition, which was a significant safety risk by all of them. And they were like, well, we've all got the same problems. Why don't we work together? Why don't we do something cross-organisationally in a multidisciplinary way and design those solutions?
You said that sometimes from health trust to health trust next door to each other might not
They
share.
don't know. Well, they just don't
Don't know
know.
what each other is doing.
I mean, there was a light bulb, or mic drop moment at the last workshop we had a couple of weeks ago, where one of the TPN specialist nurses said, "Oh, we've got some real problems with the central lines that they use to put this product into the small neonates." And she said, "Oh, there's holes all over them. I don't know if the procurement team has just changed manufacturer or whatever it is, but we're having to throw a lot of this stuff away." And around the room, the neonatologists and the pharmacists and the others were like, well, we have that as well. And so you suddenly get a perspective that's not just an organisation. You realise, this is a bit of a systems issue. We need to look at that. So there will be a little working group looking at that. Is it a particular manufacturer that's got a problem? And back to your point, sort of Martina, someone said, "Oh, well, are you reporting that on your instant reporting systems?" And they said no. She went and spoke to the nurses, and they said, "Oh, have you reported it?" And they were like, "We're too busy to report that. No one does anything anyway." So if you're not finding ways to capture that, it
just persists.
It persists, and
if you don't see the change coming from it. If those clinicians do report it and they have tried and they still feel like it's fallen on deaf ears, then are they going to be motivated to keep reporting?
Well, there's a shrugging of shoulders, isn't there? So when you see, and so this is a bit counterintuitive in some ways, when you see organisations doing more to improve based on that feedback, the incident reporting rates go up. And that can be seen, well, you've got a bigger safety.
That's a good thing.
It's a good thing. You're exposing it.
You're exposing it, but then other people are looking, and it's like when you record pressure injuries. One hospital records them differently from another. Then that hospital looks as if they've got more pressure injuries than the one beside them, where they're just recording it different.
Well, there's a lot, and there's a lot of gaming. So I was talking to a colleague who was doing some work with health systems in California, and they were looking at central line acquired infections, and they wanted to set a zero target, completely, because it's achievable in different parts of the world. They've done that, so that's what they wanted to do, and within 6 months they'd got zero reported infections. And like, well, this is really impressive. So he went out to the health systems to see what they were doing, and found that actually they couldn't achieve the target, so they stopped reporting.
Yeah, you see.
So you've got to be careful how these, it's all about, if you haven't
making
got
it look good.
And if you haven't got the right safety culture and the right leadership and you're providing support, then you're potentially doing that, which is not in anyone's interest.
No.
Martina, pressure injuries and falls, stuff related to seating and why you set up seating matters, like what do you see as avoidable patient harm or...
Well, I mean, pressure injuries, the statistics are that there is billions spent annually on the treatment of them and very little money spent on the prevention.
Yeah.
It's all about treatment and dressings and all that. So we know that we have developed, like within our setting, we've developed like the 4 principles. And we know that if someone adheres to those 4 principles of good posture and good pressure management, we can reduce pressure injuries. We can avoid them completely. And falls, I don't have the statistics on falls, but I certainly know that,
but it's part of the reason why you have developed the chairs the way that you've developed them because in our experience, proper seating, adequate seating, used correctly,
absolutely
eliminating falls. We've just done a a piece of work with a university hospital in the US, and we're getting ready to publish that. And they had it was a patient safety of falls committee. They kept having recurring problems, and they knew that it was huge cost to patient harm, patient well-being,
and a big cost to them, because they would be penalised for
and then litigation on top of all the on costs of. So they really wanted to try and establish, could better seating have an impact, and so we did a really extensive piece of work with them, and the results are outstanding. They're really they've been using the chairs for a long, maybe over a year now, and they had 0 falls in the period of time they've had session. So
I look forward to publishing that. But I know you've done quite a lot looking at the economic impact of pressure injuries and a part of the evidence base. But and it absolutely aligns to, certainly in terms of the NHS and the 10-year plan, looking at prevention as a theme. And so rather than, this is broader in terms of preventing sort of health interventions and looking at, minimising coronary heart disease and diabetes and all the rest of it. But nevertheless, the theme of prevention is something that's, I know, very dear to your heart. And, avoiding the harm and then the consequence of that for patients and families and from the health system.
So I want to come back a wee bit to yourself, personally. So what made you get in, because you're an accountant by background, is that right?
Yes, it is. Well,
just a wee bit, wind back, how did you end up in this particular...
Bit of a strange accountant anyway, so I was because I'm quite numerate, so I was always advised in terms of career, I should go into accountancy, and I'm like, you're joking, I'm never going to do that, that's just so dull. But I've always had a very strong sort of social conscious, social justice approach. So I did go into teaching, and I was very unsuccessful. I was quite rubbish at it, so I got I needed to pay the rent, so I got a temporary job, clerical job with the health authority in a finance department. And damn, I realised I was quite good at it. And then I was supported from a career point of view to one of these specialist graduate schemes. And so I was a finance director I was 30 or 31. And I was a better finance director than I was an accountant, because if you're a finance director, you are looking at financial strategy, financial planning, you're looking at kind of coordinating or working with professional colleagues. I really enjoyed that. Partly because I got the skills to do it, but I was very interested in working in healthcare. So I was finance director in the NHS for many years, and I always felt that I was there to serve the patients and the public, and what could I do to contribute to the organisation. And so kind of the whole concept of safety system thinking and delivering outcomes and outputs for the population was a real personal driver. And of course, everyone's got experience, or most people have got experience of avoidable harm in their families. And so, there have been personal experiences in my family where there was harm that was avoidable. And I do put in my bio that I don't put details down, but I do say I was affected by the organisation's response to it and the failure to learn from it. And I got really quite annoyed at circumstances and thinking, hang on, this could happen to someone else. Why aren't you taking this seriously? So I was very interested. And then Organisation with a Memory came out, which is the report that was commissioned by Sir Liam Donson when he was Chief Medical Officer. And that was really looking at safety system thinking and how that should apply to healthcare. And I read that and I thought, light bulb moment, that's exactly what I'd like to do to contribute to improving patient safety, but doing it in a more direct role than just in a professional role in the health authority. So I applied for and became Director of Operations at the National Patient Safety Agency, and kind of switched. I've always got that corporate hat on because whether I've worked in organisations or indeed in helping set up patient safety learning as a charity, you use some of your skills anyway as a manager, as a change leader and as a finance director. But from that point onwards, focused on patient safety that's what I want to do. So a bit of a strange journey from someone who did psychology at university. So.
You mentioned the Alzheimer's Society as well.
Oh yeah, so I after I worked at the World Health Organization, I had to come back to the UK for personal reasons, and so I did a number of roles. I was working at the Equality and Human Rights Commission and did a number of roles, including chief exec there when we put the Equality Act 2010 through Parliament. So again, that social justice bit. And then I worked at the Alzheimer's Society and Parliamentary Health Service Ombudsman. So my CV is kind of like scattered with roles, but at the heart of them, they're always social justice and always wanting to get back into patient safety. So when we had the opportunity to set up a charity to do more, to not to complement what healthcare as a system is doing, but we felt that there was a need for an independent voice that could work in a way that was quite agile and do things like setting up the hub. We could do that independently. Just let me at it.
Very good. Do you want to talk to us about this here before we finish off? Explain this a little bit to us.
This is about our standards framework. It comes from when we first set up patient safety learning. We didn't want to be an organisation that was just policy influencing, because a lot of charities are, and it's awareness raising and policy influencing is very important. But we use the insights we get from, we talk about listening to, learning from and promoting the voice of the patient safety frontline. And by that, it's, clinicians, patient safety experts, patients' families and others. So we get an insight from people that we work with and our networks. But when we first set up, we wanted to be clear about what our purpose was as an organisation, because you need to do that, don't you, in sort of setting up a new starter. But we wanted to share that with others, and we did that through a document called A Blueprint for Action, which was trying to answer the question, why is harm so persistent? And our reflections were in that document. And we took our evidence base from our perspectives, those of us that were helping set up the charity, but from reports, inquiries, investigations, both UK and globally. And we developed that as a series of 6 foundations for safer care. And so leadership, culture, patient-family engagement, sharing learning, having the resources to deliver patient-safe services. But one of those foundations was professionalising patient safety, which was having everyone that works in healthcare, whether you're in academics, clinical service industry, understanding principles of safety management system, being aware of recognising that it's not about blaming the individual that might have contributed to avoidable harm, but understanding behind it. And so we were promoting the idea that, as well as that perspective, that there would be, by professionalising patient safety, we needed to have a set of standards. What does good look like for patient safety? And I think we were talking at dinner last night, we were saying in terms of fire safety, every organisation needs to have a strategic focus, which is predominantly avoid having fires, put them out quickly. But then you've got a whole framework around delivering that. So you've got a set of you've got goals, you've got standard operating procedures, you've got an assurance framework, you're monitoring, you've got people that are trained, you've got a whole framework. And that's not quite the same, in our view, in patient safety within healthcare. So organisations have to respond to what regulators require of them, system regulators, but actually having that whole sense of, well, what is your ambition as an organisation for safety? Where's your baseline? Where are you now? What do you want to do? And what's the framework that you have in place? So rather than waiting for a regulator to come and tell you whether you're safe or not, you should know. You should know where your risks, your hazards are. You should have a set of ambitions, wherever your ambitions are for improving patient safety. It's informed by an understanding of what your baseline is. So we were arguing that that standards framework was something that was needed in healthcare. And we had some very positive conversations with people about the value of that approach, and there are internationally some people that are working in this area, but we felt there were gaps and that we could contribute to that. And so because there wasn't something that we felt that was of sufficient depth, that we created that ourselves. So we've created a standards framework for patient safety using those foundations as the start point. And since we published, the WHO have published their Global Patient Safety Action Plan, which have very, very similar themes. But our standards framework are the standards, and 144 of them. So it's pretty comprehensive across these foundations. But I think what's really particularly of value is that if you're going to self-assess against those, you have to know whether, so if you had just picking one in terms of leadership, have you set yourself a plan? Do you have an ambition? And people go, oh, yeah, we do that. But then if you look at what we've developed alongside the standards, which is an output and outcomes framework, which is, well, do you have that plan? Is it regularly reviewed? Is it based on good practice? And outcomes, are those... Is it known? Is it approved by the board? Are the board actually implementing it? Do they monitor it? So you've got a whole series of questions to ask yourself. In reality, you might have it as a commitment, but are you doing it? Yeah. And then you can evaluate yourself against that. We've got a framework which is essential, enhanced, and exemplary. So it's intended to be very positive. If you can demonstrate you're at an enhanced level, great, something to celebrate. But if you've got some of the essential standards that you're not achieving, then that enables you to have to consider where you prioritise your resources on your improvement journey. So that's the framework that we helped Great Ormond Street Hospital.
I was just going to say, who has implemented this? Yeah, Great Ormond Street's one.
Yeah,
they're using it.
Yes, they have been using it, and the chief medical officer was very keen there that we had a kind of an evidence-based framework, and he'd not long been appointed as chief medical officer after the Care Quality Commission came in and said that actually it requires improvement, and that was a bit of a shock for GOSH because they're a very good organisation. Yeah. But, this was not kind of where they wanted to be. So they've used this to help develop their transformational change programme, and their recent CQC assessment said they were good. So
very good.
Still more to do, but they're on that journey. So part of what we're doing is proposing how other organisations can use either the whole standards or elements of it to help them on their journey. So it's a slow burn. No one requires them to do it, but I think it's the way forward in terms of the safety system. Thinking that ownership and particularly at the organisation level, to be able to demonstrate that you know where you're starting from and what your improvement journey is.
And like ourselves, it's continuous improvement. It's you're never going to get there. It's going to be every day, every week, every month, every year. You're going to look at it and you're going to keep improving.
And anything that's, any organisation that has people working in it, there will be variability and people will turn around, and then there are different priorities, different resource environments. So yes, it's quite a complex and complicated environment, and it's volatile, so you have to be on it. It doesn't, you can't be complacent in this.
I have a little question, but maybe it's a big question.
Go.
So we're talking all about patient safety, and I know that's what the charity's about. What about staff safety?
So I think patient safety as a kind of mindset, as an activity, probably didn't reflect well enough on patient safety. So you would often have occupational safety and patient safety, and that really came to the fore, I think, during the during pandemic. And actually the World Health Organization responded with, staff safety, patient safety, two sides of the same coin. So much better understanding of actually you cannot have patients safe unless your staff are safe and unless they're given the resources and the environment to work in that allows them to do of their best. So that's a key area, certainly around organisational culture and some of the things I talked about, not speaking up. And we're actively been doing some work recently with Peter Duffy, who's was a consultant urologist and has been a whistleblower highlighting concerns around safety in his organisation and how he was treated. He's written a couple of books. You can find the details on the hub. They're amazing, quite frightening to read. But to demonstrate what happens when organisations don't embrace feedback from people saying we need to do things differently around here, and then treated in a hostile way. So there's a lot more to look at, both physical safety and psychological safety. I'm president-elect for the Royal Society of Medicine Patient Safety Council. One of the projects that we've got is a big conference we're going to be doing next June, which we haven't put in the public domain yet, but right anyway. But we're planning, looking at culture, and the whole session is on psychological safety and the positivity of it. But we've got on the hub a number of interviews that Peter and I have done with whistleblowers and people that have been talking not just only about the culture, but also physical safety. And we had Chelsea, can't remember her surname, she and a colleague set up Surviving in Scrubs, which is looking at misogyny and sexual harassment, particularly by women, but not exclusively in healthcare. So, and then there are other things. If you look at human factors and design, the number of female surgeons that have to stand and do surgery on a box because everything is at a level that is suitable for 6'2" men. So we're needing to design things, and you'll know far more than me about this in terms of occupational health and safety of staff and back injuries for nurses and others if they haven't got the right equipment for lifting and handling for staff.
Right training as well.
Yeah.
One of the businesses that we have is A1, and that's a specialist moving and handling training business.
Okay. Well, then
an organisation that is just to make sure that the staff, whether it's medical staff, nursing staff, or just general care staff, that everyone is trained up to standards that they don't injure themselves or the patient.
Yeah, absolutely. And then there's all the issues of kind of burnout, working in an environment that is very stressful. And then we were talking last night about challenges of retention of staff and some of the sort of hidden consequences of that, where staff that are coming out of formal education but are then being promoted very quickly, so often reaching more senior positions earlier in their career than they might have done 10, 20 years ago, but not necessarily being equipped with the experience and the skills to enable them to do the job as well as they want. So it's stressful for them, but it's then not providing the support for those coming through. So there's a whole series of issues around workforce and safety. So patient safety is kind of an umbrella term, but
I like that idea that it's two sides of the same coin.
Yeah.
Well, it is actually.
Patient safety can't be executed properly if the staff, if the people delivering the care don't feel safe.
Yeah, yeah,
that's right. So just sort of to summarise, and I want to end on one thing, so your mission really is raising awareness of avoidable harm, and you used an example about the jumbo jet. Tell me that, because that stuck in our mind.
Oh, well, that's, so it's raising awareness, but it's also providing people with the resources and knowledge and networks to identify good practice and implement it, so making a difference. But the jumbo jet, Sir Liam Donaldson used used to have a visual that was a jumbo jet crashing every fortnight. So if you looked at the number of avoidable deaths from in healthcare, 230 people dying a fortnight, and that's the equivalent when you look at that visually. It's huge, and one of the things that we talk about is it's almost the cost of doing business. It's almost not normalised the level of harm that happens, and that's globally, because tackling it is not easy. You are. If there was a magic wand to do this stuff, it would be done. This is about delivering a safe and effective healthcare, about getting the right quality improvement, the right culture, all those things that we've got in our foundations. But yes, we need to remind ourselves that this is a significant issue, and in a post-COVID world where there are pressures on health system, where the demands of health system by older people with multiple morbidities, the pressures are ever greater. And without designing for safety, then the risks are going to be, greater. And we need to make sure that the scale of avoidable harm is reduced rather than just, maintained or contained.
So I always like to end on a positive note, because I've been doing my job for 25 years, this particular job in seating and pressure management, and I could get overwhelmed when I still even go to like care home down the road and see how people are sitting, even after all the training I've done. But then I have to take a step back and think of all the positives and all the people that are sitting correctly. And so we have made a small contribution. And like yourself, you could get overwhelmed, but it's good to just take that wee step back and see that every day you are making an incremental difference.
That's right. And one of the networks, the biggest network that we support is the Patient Safety Management Network. And it's for anyone that works in patient safety, whether you're a patient safety partner, or you're a clinician, whether you're a patient safety manager. Over 2,000 of them now. There's a drop-in session between 2 and 3 o'clock on a Friday afternoon. And you'd think Friday afternoon, talking about patient safety, oh gosh, people are going to be gloomy for the weekend.
You'd think.
There is so much positivity. People that work in this space, that join us on those meetings, they are incredibly positive and energised and committed people, and sharing knowledge for improvement is that knows you're going to make a difference. It's fantastic. That's so right. It can be positive.
And and the fact that we're even talking about it, and the fact that you exist, and the fact that you are full of passion about it, that's a positive in itself, because it means it has been talked about and you are doing things about it all the time, and that will continue, so you're going to have a legacy there. So
yes, hopefully.
I want to thank you both, Dearbhaile, for bringing you here and for doing your research, and for bringing you, because it was a very interesting
it's a three-way interview. This is
thank you very much, and thank you, Helen, for coming. And
you're welcome.
As I say, we do have a lot of similarities in the way we do things, and we want to continue that collaboration.
We will do indeed, and we'll put on, if we may, at the very end of the video, the link to the hub,
absolutely,
so that people can access that and learn from it, but also contribute to it. So with good practice. So I'm looking forward to putting a lot of information about what you do and your ambition on there as well.
Thank you very much.
Thank you.
Thank you.